Sure, I don't think in the time remaining to get to many of them. Certainly, health homes are critical with the team-based care to really help people, and I think delivering care in that team-based fashion, which is the name of the game right now, will help to control costs and make sure people's wishes are followed. There are so many things that nurses do so much better than doctors do that we need to be comfortable asking them and making it possible for them to do it. When I practiced at Dartmouth, I'll give you a tiny example. A partner and I, for fun, one day looked at how many of our patients on Coumadin, a blood thinner, which is really critical. That too much is bad because you have a stroke and you die. Too little is bad because you have a blood clot and you can die. So it's kind of something important to pay attention to. And we went through all of our charts, and we noticed that we were about 50% of our patients were within a target. Weren't perfectly on, get a range is how you want to manage it. And we thought, wow, we'll try harder. So a month later, we were at 52%. We were really pleased with our success. And I had this nurse who more or less drove me nuts because she was fairly obsessive compulsive. But if you could get her on the right bones to chew on, and she said, let me take this over. She was this crusty Vermonter. Within a month, she had everybody, 98% of the patients were at control. And she knew the two people who were not coming in, why they weren't coming in, what their situations were. I never had any idea. So we need to be brave to turn that over to other people on our care teams. Families, parish nurses, other people, we should think that there's a broad network that needs to be activated to really care for people who are sick. You know, the electronic health records are really nice if they're used and people go in them. Obviously it avoids duplication, make sure the information's at someone's fingertips. It's a little harder to order another CT scan because you just can't quite find the results when it's one mouse click away. Things like that. And the medical errors and patient safety organizations, we all want to have safe care. The current system doesn't dun people necessarily for making errors, and it is a human system and errors will happen. But we should do all that we can to mitigate that so people have as safe an experience as possible. And it's a complex, complicated world of healthcare delivery. Some people liken it to being a captain on a nuclear submarine. So those are my brief comments on a few of those.
I don't have much to add. These are all some of the tools that people who've been researching healthcare for decades have suggested. These would be some of the ways that we could reorganize care and do it better. And the good news is there really is a lot of room for improvement in our system. It's a good news, bad news story. You might be really shocked to hear that some of the best research that's been done suggests that fully 30% of all the dollars we spend on healthcare don't buy us any more health. That's a very large number, 30%. Now that should give us cause for some optimism that it is possible to actually have a lower cost system that produces equally good or better results. We're letting ourselves get scared off of thinking that reform means that we're all going to lose. I do agree that it's going to require change, and it's going to require choices, and it's going to require getting really explicit about what our values are. But the data are pretty clear. Doing care in some of these ways definitely costs less. It's possible to spend a lot less and produce better outcomes. That's the hope.
I'll just give one quick example of adoption of standard-based protocols. We can't be too prescriptive in how we set up protocols because technology and things that we learn over the years and out of outcome, we don't want to write that statutorily in, so we can't do the innovation and the things that we need to do. We need to let not government do those kinds of regulations. We need to let the healthcare experts set the expectations and then lead. But it was amazing to me. We had a hearing about what was going on in hospitals with hospital-based infections, these superbugs that are becoming resistant to the antibiotics that are around there. Little things like checklists and you could speak to this clearer than I could, checklists in ORs. Little things like when you go into St. Joseph's Hospital, they'll have a little sign up when you go to see a newborn baby saying, please wash your hands and sing Twinkle, Twinkle, Little Star to your new little friend. Just those few extra minutes of making sure that somebody washed their hands and did it. And by the way, you could walk down the hall that day and hear people singing Twinkle, Twinkle, Little Star, and everybody was jumping into it. Reduce the amount of infections. It reduces the amount of admissions. There's some things that we know work, and some people just refuse to look at how to do it. Now, if you refuse how to make patients safer, and we can, and in Minnesota, that's why we have all the transparency we do on hospitals, then pretty soon, if you know it's going to be published that you have more readmissions than other people, or people are getting sicker in your hospital, you're going to do something to change it, or people are going to pick up and go where it's better. I think that the key to this is transparency and listening to the medical community, and that's what most of those things up there are all about.
I know we're over our time a bit. There are a couple audience